Asthma is an episodic, chronic respiratory disorder characterized by airway obstruction caused by inflammation and hyperresponsiveness of the bronchial smooth muscle. The two golden words in asthma are reversible, which means that the obstruction can virtually disappear with medications like bronchodilators, and inducible, which means the obstruction can happen in response to a variety of stimuli, including allergens like house dust mites, pet animal dander like cat dander, and pollen, or irritants like tobacco smoke, respiratory tract infections like a common cold or pneumonia, cold or dry air, and even emotional stress. Now, atopy is the genetic predisposition of an individual toward developing IgE antibodies to otherwise harmless environmental antigens, making that individual strongly predisposed to developing three allergic disorders: eczema or atopic dermatitis, allergic rhinitis, and asthma, collectively coined the atopic triad. Because of this genetic component, asthma is usually diagnosed in early childhood, and may or may not carry on into adulthood. So let's say a genetically predisposed child is exposed to a potential allergen for the first time. First off, dendritic cells take up the allergen and present it to a type 2 helper T cell, or Th2 cell. In asthma, Th2 cells make the mistake of thinking this harmless antigen is an allergen, so they release cytokines that stimulate B cells to make IgE antibodies. IgE antibodies then prime mast cells, which cautiously anticipate the next event. When the child is re-exposed to the allergen, the mast cells spill out vasoactive mediators like histamine and leukotrienes, which cause bronchoconstriction and inflammation. Once the child is no longer exposed to the allergen, the immune system relaxes, and everything goes back to normal until the next event. Now, not all asthma episodes are triggered this way by an allergen. A unique form of asthma is aspirin-sensitive asthma, which is characterized by the triad of asthma, nasal polyps, and sensitivity to aspirin, or NSAIDs. Aspirin opposes prostaglandin production, and tips the balance between prostaglandins and leukotrienes in favor of increased leukotriene production, which promotes smooth muscle contraction of the airways. Alright, so patients with asthma have intermittent episodes of dry cough, chest tightness, and shortness of breath. Some patients have just a single symptom, like cough, making the diagnosis more difficult. These symptoms usually happen in the daytime, but can also happen at night. On auscultation, there will likely be wheezing during expiration, because that's when the airways collapse and become narrow. Percussion might reveal hyperresonance, which indicates that the bronchoconstriction has led to air trapping and hyperinflation. Severe episodes are ones where a patient struggles to breathe. They might only be able to speak in short phrases, and might need to use accessory muscles like the scalene muscles of the neck, or the intercostal muscles of the ribs to help with breathing. But as the saying goes, all that wheezes isn't asthma. For example, chronic obstructive pulmonary disease, or COPD, can also cause wheezing, but it's more common in the older patient who smokes. And in COPD, the symptoms are often irreversible, because there are permanent changes to the architecture of the lungs. Another one is aspiration of a foreign body, which might obstruct an airway and cause wheezing in one area of the lungs. This usually happens in young children, and there's often a sudden onset of wheezing and cough along with the history of the child being unobserved or potentially swallowing something. Bronchiolitis, or inflammation of the small bronchioles, is often seen in children less than 2 years of age, and presents with acute cough, wheeze, and shortness of breath, following an upper respiratory tract infection like a common cold. Gastroesophageal reflux disease, or GERD, can also mimic asthma, with symptoms like chronic cough and wheezing. However, the patient is often an obese adult, and symptoms often improve with proton pump inhibitors. Allergic bronchopulmonary aspergillosis, or ABPA, is an allergic response to aspergillus antigens, and usually happens in the setting of asthma or cystic fibrosis. ABPA presents with wheezing and high serum IgE levels and eosinophil counts. However, chest radiographs often show recurrent pulmonary infiltrates. Finally, there's Churg-Strauss syndrome, which is a small vessel vasculitis that's associated with eosinophilia and wheezing, But patients also have skin purpura and peripheral neuropathy. Okay, so when asthma is suspected, the first step in diagnosis is conducting pulmonary function tests, or PFTs. The most important measurement are the forced vital capacity, or FVC, which is total volume of gas exhaled after a forced maximum expiration, and the forced expiratory volume at 1 second, known as the FEV1, both of which are decreased in asthma. Now, because asthma is an obstructive lung disease, the FEV1 is decreased to a greater degree than the FVC, so the ratio of FEV1 to FVC is usually less than 80%. Also, because asthma is episodic in nature, the PFTs are only abnormal when the patient is having symptoms. If a person is symptomatic, the next step is to give a bronchodilator like albuterol, which reverses the PFT measurements back toward normal, confirming the diagnosis of asthma. A significant reversal is defined as an increase in the FEV1 by more than 12% from baseline. If the reversal is less than 12% after giving a bronchodilator, then the patient is less likely to have asthma. Now, if you do PFTs on asymptomatic patients, they'd be normal, since asthma is an episodic disease. So in this case, we try to induce asthma symptoms by performing the Methylcholine challenge test. Methylcholine is like acetylcholine, so it binds to muscarinic receptors on bronchial smooth muscles, causing mild bronchoconstriction. In a healthy individual who doesn't have asthma, the bronchoconstriction is negligible and does not cause a significant change in PFT measurements. But because an asthmatic patient's bronchial smooth muscle is hyper-responsive, methylcholine causes a 20% decrease in their FEV1 from baseline. Remember the golden asthma words, reversible and inducible. Now, some additional tests are not specific to asthma, but they might help with diagnosis. A complete blood count, or CBC, might show an increased eosinophil count. Serum IgE levels might also be increased. And skin testing might help identify specific allergens that the patient can subsequently avoid. That involves injecting small quantities of known allergens into the patient's skin, and then observe to see if the immune system overreacts to it. Okay, so after diagnosing asthma, the next step is to determine how bad it is. Asthma severity is classified as intermittent, mild persistent, moderate persistent, or severe persistent. As the severity of the asthma escalates, so does the complexity of treatment plan. Specifically, the type of chronic treatment the patient requires. In terms of medications, the first class are bronchodilators, which include short-acting beta agonists, or SABAs, like albuterol, and long-acting beta agonists, or LABAs, like salmeterol. The second class are anti-inflammatory medications, which include inhaled corticosteroids, like budesonide or fluticasone, leukotriene antagonists, like montelukast and xyluten, and oral corticosteroids, like prednisone. The third and final class of medications are mast cell stabilizers, like cromolyn. Alright, so classification of asthma severity is determined by 4 parameters: the frequency at which the patient experiences nighttime symptoms, the FEV1 in between exacerbations, and the degree to which the asthma interferes with the patient's normal daily activities, like going to work. Children less than 5 years of age can't usually follow PFT instructions, so the FEV1 parameter is eliminated. Now, intermittent asthmatics have less than 3 daytime symptomatic episodes per week, nocturnal symptoms less than 3 times per month, an FEV1 more than 80%, and no interference with normal activity. Intermittent asthmatics can be managed with a SABA, given only during the symptomatic episodes. Mild persistent patients experience daytime symptoms 3 or more times per week, but not every day. Nocturnal symptoms 3 or 4 times per month, an FEV1 more than 80%, and have a minor limitation in activity. In addition to using a SABA when needed, mild persistent asthmatics are also started on low-dose inhaled corticosteroids, which are administered daily. Moderate persistent asthmatics experience daytime symptoms every day, so 7 times a week, have 1 or more nocturnal episodes per week, but not every night, an FEV1 between 60% and 80%, and have moderate limitation with normal activity. In addition to using a SABA when needed and low-dose inhaled corticosteroids, they're given a LABA as well. However, children less than 5 years of age with moderate persistent asthma escalate their inhaled corticosteroid to a medium dose, and no LABA is added. Severe persistent patients experience daytime symptoms throughout the day, have nocturnal symptoms nearly every night, an FEV1 less than 60%, and have extreme limitation in normal activity. In addition to a SABA and a LABA, the dose of the inhaled corticosteroids is increased in these patients. Children less than 5 years of age might also alternatively use Montelukast instead of the LABA. In patients with other allergic symptoms like allergic rhinitis or eczema, who might have an elevated serum IgE, the monoclonal antibody omalizumab can target IgE, providing additional benefits to patients who are already on high-dose inhaled corticosteroids and a LABA. Finally, if the asthma is refractory to these medications, then systemic oral corticosteroids are added. Oral corticosteroids are only used as a last resort, because unlike inhaled corticosteroids, they might have adverse systemic effects, including osteoporosis, cataracts, hyperglycemia, adrenal suppression, and fat redistribution. Now, before considering a patient's treatment plan, it's important to consider the fact that a patient is either not taking their medication or they're not using their inhaler correctly. That's why it's super important to offer education on how to properly use an inhaler. Other patients might be suffering from adverse effects of inhaled corticosteroids, like hoarseness or oral candidiasis, which might be the reason they aren't using it. Finally, other medications like leukotriene receptor antagonists and mast cell stabilizers are helpful in atopic patients, but are never first line. Now, all of this medication escalation works great in a clinical setting, but when there's an acute exacerbation in an emergency room setting, there's no time to do PFTs, and some patients are so short of breath they can barely talk, let alone give an elaborate history. That's why, in an acute asthma exacerbation, the priority is to relieve the current episode, and figure out if a patient needs to head home, to the inpatient floor, or to the intensive care unit, the ICU. The best initial test is a peak expiratory flow rate, or PEFR. The PEFR is essentially the fastest and the hardest a person can exhale after a full inspiration. PEFR is kind of like a bedside mini PFT. Not quite as reliable, but super useful in an emergency setting. A normal PEFR is typically greater than 70% of the predicted peak flow for the patient's age. Now, in the clinic setting, we previously classified the severity of asthma based on symptom frequency, FEV1, and activity, and that determined the patient's long-term treatment. On the other hand, in the acute setting, asthma exacerbations can be classified into mild, moderate, severe, life-threatening, and near fatal, based on the severity of the current symptoms and the PEFR. Now, an additional test is an arterial blood gas, or ABG, and it's useful in a severe or life-threatening exacerbation to determine if the patient is retaining carbon dioxide, which can be a sign of impending respiratory failure. Mild exacerbations are characterized by symptoms only with activity, and a PEFR greater than 70%. Patients with mild exacerbations rarely come to the emergency department, because most of the time their symptoms go away after using an inhaled SABA. Moderate exacerbations are characterized by symptoms that don't readily improve with a SABA, and a PEFR between 40 and 70%. Mild and moderate exacerbations usually don't require an ABG. Severe exacerbations are characterized by any one of the following: a PEFR between 25 and 40%, a respiratory rate greater than 25 breaths per minute, a heart rate greater than 110 beats per minute, or if the patient is unable to complete sentences. Moderate and severe exacerbations show a low partial arterial pressure of carbon dioxide, or PaCO2, on an ABG, which is normally between 33 and 45 millimeters of mercury. This happens because the patient is breathing really fast and blowing a lot of CO2 out. Finally, life-threatening exacerbations are characterized by any one of the following: a PEFR less than 25%, an oxygen saturation less than 92%, an altered mental status, absence of wheezing, and a normal PaCO2 on the ABG. Now, you might be thinking, no wheezing and a normal PaCO2 sounds normal. But a silent chest in the context of worsening asthma is a terrible sign, because it means the obstruction is now complete. In other words, there's literally no airflow to even create that musical wheezing sound. Also, if a patient is having an asthma exacerbation, we expect the PaCO2 to decrease. But if the PaCO2 is normal, that means they're tiring out, and the patient is beginning to retain CO2. Finally, a near-fatal exacerbation is when all those medications don't work, and patients have an elevated PaCO2 and can no longer breathe on their own, necessitating ventilatory support. Generally speaking, a chest X-ray in asthma is usually either normal or shows hyperinflated lungs, but in an acute setting, it's obtained to rule out an underlying cause of the asthma exacerbation, like pneumonia. But the idea is not to wait for ABGs and chest X-rays in an exacerbation. Treatment begins immediately with oxygen using a non-rebreather mask, with the target oxygen saturation being above 92%. Right away, it's important to start a SABA like albuterol, with a nebulizer or with a metered dose inhaler to reverse the bronchoconstriction. Also, ipratropium bromide is an antimuscarinic medication that might be given in cases of severe exacerbations. Both are typically given as 3 doses given 20 minutes apart. Oral or intravenous systemic corticosteroids should be given to reverse the inflammation. If the patient isn't responding to the bronchodilators, or if they're having a life-threatening or near-fatal exacerbation, intravenous magnesium sulfate might be added. Magnesium sulfate works by inhibiting calcium influx in the smooth muscles of the bronchi, causing vasodilation. Finally, unless the patient actually has a concomitant pneumonia evident on chest X-ray, routine antibiotics are not indicated in asthma exacerbations. Now, after providing treatment in the emergency department, if the PEFR is greater than 70% and the patient's symptoms have completely reversed, they can go home. But before sending your patient packing, make sure you arrange a follow-up plan in the clinic to see if their asthma severity is worsening, and to check if they know how to use their inhaler. If the PEFR is between 50 and 70% and the symptoms are incompletely reversed, then the patient can be admitted to floor, where the patient can be observed, and treatment can be continued. If the PEFR is less than 50% and the symptoms are not improving, then the patient should be taken to the ICU, where the patient might need positive pressure ventilation or intubation in the most extreme situations. Finally, when discharged following an exacerbation, all patients are put on a brief course of oral corticosteroids for 5 to 10 days, which significantly reduces the risk of another exacerbation within the next 2 weeks. Alright, as a quick recap. Asthma is a chronic condition with reversible airflow obstruction, bronchial hyperresponsiveness, and an underlying inflammation, all of which lead to recurring symptoms like wheezing. Based on symptoms, patients are categorized as having intermittent, mild persistent, moderate persistent, or severe persistent asthma. Treatment plans initially include a short-acting beta agonist, but step up as needed to include stronger medications like long-acting beta agonists and inhaled and oral corticosteroids. Asthma exacerbations are classified into moderate, severe, life-threatening, and near-fatal. Initial treatment includes nebulized bronchodilators like albuterol and ipratropium, as well as systemic corticosteroids.